Dr. Chahal or Shadrach can come.
No, the alarm, I think you guys are doing it, no? Have some sort of what you were doing the last time. 2 minutes before the time, just alert the speaker.
Okay, doctor.
We will give some 2 minutes more to Harun sir because he will show those procedures which are very important.
Yeah,
which are part of the treatment.
Ultimately, you're the timekeeper.
No, no problem, sir. Good evening, sir.
Hi, Samjit. Hi, Santosh. Hi, Santosh.
Good evening, Dr. Santosh. Good evening, Dr. Samjit.
Good evening, sir. Good evening, everyone, sir. Santosh here, sir.
Santosh is one of our founders of the webinar.
Yes, sir.
So I request
1 year we have been. Thank you, Santosh sir, for being present.
Yeah.
It's a pleasure to have you here.
Yeah, thank you. My laptop is still not turning on. I've logged in through my phone. That's why I was a little late, sir. Sorry, sir.
I requested Santosh to join us today since.
Sir, I was trying to find the flow chart. 1 second. I think you had shared it much earlier.
Yeah.
I have it in my.
Sir will start with the introduction to this
yes.
webinar, then the lamp lighting, then I'll take over. Then I am the first speaker, then you are the second speaker, then Dr. Somyajit Basu, then we'll discuss 2 or 3 cases.
So just request that try and keep time as much as possible, and we'll leave more time for discussion with amongst yourselves and with the audience also. I'm sure there'll be a lot of questions because I've not. This is the first time I'm listening to a webinar on tendinopathies around the spine. So I'm planning to listen to every word you guys speak. Santosh, we told all our boys, DNB boys to join.
Yes, sir. I have told them, sir.
So we have around 7,000 and 8,000 today.
Registrations.
Yeah.
We hope that most of them will join.
Yeah.
Yes, sir.
Sir, that is an amazing number. We need to motivate radiologists as well.
No, the Farmet team does a lot of work, and then we actually circulate it through the Anbai groups, through the CAHO groups, HPI groups. Anbai has got a very strong network, especially after Rupendra took over as academic coordinator. He's been very active and a lot of visibility.
Have you gone through the cases, Rupinder? You're muted.
Yes, sir. He showed me a few cases. Do you have any case to show, sir? Or
all googlies or bouncers?
It's all of those which we said mechanical back pain or psychosomatic. Today I was feeling little, after having read some of these tendinopathies and all, I was telling sir, I was feeling little guilty. We didn't look into this. We looked at bones and nerves only, never looked at the muscles. Especially this happened, sir, when we shifted from open discectomy to microscopic. And then we said, what crime we were doing, that time, now ours is 100% microscope.
Right.
So we, apart from visibility, elimination, and all those things make a great difference. So the same feeling I had after studying then little bit of tendinopathies.
No, actually, I think there are not enough diagnostic markers, radiological or diagnostic markers for determining those particular tendinopathies. And that's why it's more of an exclusion of events in our practice. And that's why we are not very keen to pick these up. That is our problem.
But sir, if you have a very good musculoskeletal radiologist, who does those ultrasounds and all, and basically with the blocks and all, because we have a very good department in Gangaram, like most of the things have picked up. So they are really now into a lot of things. Their OPD is biggest than even the pain management in the spine.
No, the problem, Rupinder, is the fact that a patient, a surgeon who has a busy practice, he doesn't spend time in non-surgical issues.
Yes.
If he thinks that something is there which is surgical for me, he will go into the depths of it, spend time on that. If he finds a patient that it's not surgical from the word go, he would just send it out to somebody else. And that person, if he is really, really very keen on picking up non-surgical aspects of back pain and spends a lot of time repeatedly, sees patients at multiple visits in the OPDs, then he will be able to pick it up. Otherwise, it's extremely difficult for a surgeon to pick it up.
But it's important, no, that we do it.
Absolutely important. Extremely important.
Samajit, which hospital are you in? I'm coming to West Bengal in September to.
I'm in Kothari Medical Center.
Okay. We are presenting a plan to the government on how to upgrade West Bengal's health sector with the new government. No.
The current health minister is my batchmate and schoolmate.
Okay. Oh, we are in touch with him. He's an advisor, no, health minister, and so we are trying to make West Bengal a happening place.
You can take my name. He's a very, very, very old friend of mine. We've been together for 40 years because we were in the same school as Calcutta Boys School, and then we studied in the same college, in the same batch. So,
Okay. Good. We'll rope you in because I think there's so much to be done in West Bengal, no?
Absolutely. I'm just an email away.
Oh, yeah. I'll give you a call when I.
Yes,
Saurabh, you
please.
have 1 minute more? Anything else? All set, Saurabh? Chandrasekhar is also here. Saurabh, you can hear us?
Yes, sir. I think all are set. 1 more minute to go.
Oh, it's 8 o'clock. You can start, no? It's.
Yeah, I'll start off.
Yeah. With everybody's permission, and all the best to the speakers. Looking forward to hearing from you.
Nicola.
I'll call you back.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च मतिं स्वच्छां हि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठेत् गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Good evening to all of you. On behalf of ANBAI, the Association of National Board Accredited Institutions, Dr. Chahal, who is our academic coordinator, and myself, I'm the patron of CAHO. We want to welcome all of you to today's webinar. Today's webinar is actually the 6th in a series of webinar on tendinopathies. And today's webinar is on a very, very interesting subject, a very interesting and relatively little known topic, tendinopathies around the spine. We are very fortunate to have a very extremely distinguished faculty, Dr. Chahal, Dr. Somajit, and Dr. Harun, all internationally acclaimed experts and highly respected authorities in this area, the area of the spine. I also want to acknowledge the presence of Dr. Santosh, a senior consultant in Baptist. He has been one of the pillars as we started the series of webinars more than a year ago. Also want to acknowledge the team from PharmEd, Dr. Chandrasekhar, Saurav, and Arvind, and the colleagues from PharmEd. And I also want to thank PharmEd for facilitating this series as part of their contribution to upskilling of young orthopedic surgeons. Like all of you, I'm really looking forward to listening to other experts and looking forward to the next hour of discussions. So over to you, Dr. Chahal.
Good evening, sir, and thank you for a lovely introduction. So as we have, sir is our mentor and initiator of this program, and sir is the main health provider, I would rather say the assistant to every government. And he started the APHI, he started the COW, he started the NBI, and he's one of the most active person. And if you even call him anytime or write to him, you will get a reply in 1 minute. I from Gangaram Hospital, I am associated with NBI now as a teaching coordinator, and we are also very lucky to have Dr. Harun Gupta, who's visiting us from Leeds, and he's the consultant musculoskeletal radiologist at the Leeds Teaching Hospital, and he's the founder of mskteachingroom.com. It's a highly acclaimed online teaching program, and if you say Harun, everyone knows in his world. And Dr. Basu, my senior colleague, is the head of department and program director of spine at Kothari Medical Center, Kolkata. He is the present president of spine surgeons of West Bengal and the past president of spine surgeons of India. And he's a chair and regional course committee of Scoliosis Research Committee and AO Knowledge Forum. And I will set the ball rolling. So when it isn't the spine, the clinical recognition of tendinopathy in spine practice. So good evening. Every spine surgeon has a patient who continues to have pain despite a perfectly reasonable MRI diagnosis and appropriate treatment. Many of these patients don't actually have pure spinal pathology. Today, I'd like to discuss one of the most commonly overlooked pain generators, the tendinopathies around the pelvis and the spine, and how a 2-minute bedside examination can completely change our diagnosis. So there are 6 reasons we miss these patients. First, we anchor on spine before examining anything. Second, once the MRI shows degeneration, our diagnostic search stops. Third, the tendon pain often refers to the leg and mimics radiculopathy. Fourth, we rarely palpate the tendon insertions. Fifth, we still think of tendinitis as inflammation rather than a failure of load adaptation. Finally, the most important, both disc disease and tendinopathy frequently coexist. Mistake is usually made before ordering the MRI, not after looking at it. So tendinopathy is not a tendinitis. The concept changes the treatment completely. Tendinopathy is not primarily inflammatory. It is a problem of collagen disorganization and reduced load capacity. The tendon progresses from a reactive stage to disrepair and finally degeneration. One practical message I would like everyone to remember is this: a compressed tendon should never be aggressively stretched. Stretching often worsens the symptoms because compression increases at the insertion. We all recognize overload after running or heavy lifting. What we often miss is a compressive overload. Gluteal tendons are compressed in hip adduction. Hamstring tendons are compressed while sitting. Iliopsoas is compressed while deep hip flexion. That is why patients often tell us stretching made them worse. So this is probably the most useful slide of today's talk. The tendon pain is usually a dull, deep, dull ache. Reticulopathy is burning or electric. Tendon pain is load dependent, whereas reticular pain changes with spine, posture, or coughing or sneezing. Morning stiffness improves after movement suggests a tendon. Neurological deficit suggests a nerve root. Perhaps the two highest yielding bedside findings are point tenderness over a tendon insertion, a complete normal neurological examination. If both are present, think tendon before the nerve. Before touching the patient, 8 simple questions often establish the diagnosis. Can you lie on your side? How long can you sit on a hard chair? Does the pain go below the knee? Was there a recent activity increase in activity? Does it warm after moving? Did stretch help or make it worse? These questions take less than 3 minutes and frequently separate tendinopathy from reticulopathy. So, focus physical examination. My examination always includes both hip and the pelvis anthesis. Observe the gait. Look for Trendelenburg. Palpate the greater trochanter, ischial tuberosity, iliac crust, and iliolumbar regions. Then perform resisted load testing. Finally, this is mandatory, complete the neurological examination. Only after doing both, we can confidently diagnose tendinopathy. If I find any of these 3 findings, reproducible tenderness, positive load test, and a normal neurology, I examine the tendon first before ordering an MRI. The imaging trap. As a spine surgeons, we all love MRIs, but remember that by age 60, 90% of the asymptomatic people already have a disc degeneration. Finding degeneration does not prove it is causing today's pain. Clinical examination should always outrank a discordant MRI. The diagnostic mistakes which we commonly make, the common errors are familiar: ordering an MRI before an examination, calling everything tendinitis, giving injection first, prescribing stretching, and assume only one diagnosis exists. And many patients actually have both spinal disease and a tendinopathy. There are two more further traps: ignoring the metabolic profile of the patient and missing the red flags. So let's now look at the 5 tendons every spine surgeon should examine routinely: the gluteus medius tendinopathy, proximal hamstring, ilios vas, quadratus lumborum, and the paraspinal. The gluteus, this is probably the commonest misdiagnosis. Patient cannot lie on the affected side. Pain remains above the knee. Tendon is exactly over the greater trochanter. Single leg stance produces the symptom, and the neurology is normal. Whenever lateral thigh pain does not cross the knee, I always examine the gluteal region. So, reproducing tenderness over greater trochanter plus pain on leg stance, normal, does not cross the knee. This is the key differentiator. The hallmark is sitting pain. In proximal hamstring tendinopathy, patient points directly to sit bone. Driving becomes difficulty, standing relieves symptoms, direct palpation reproduces the exact pain. There is a proximal hamstring tendinopathy until proven otherwise. The anterior groin pain after rising from a chair or climbing stairs should raise suspicion of ilios vas tendinopathy. Resisted hip flexion reproduces pain. Neurology remains the normal. Remember this particularly after hip replacement, where ilios vas impingement is often overlooked. Cuval insertion pain often mimics facet or SI joint pain in a quadratus lumborum insertional pain. Patients have localized tenderness between 12th rib and the iliac crest. Resisted side bending reproduces the symptoms, but always exclude renal pathology before making this diagnosis. Paraspinal tendon and anthesis disorders. Think of this as an under-recognized cause of focal load-related back pain, particularly after surgery. Look for a reproducible anthesial pain point with normal neurology before further imaging. Consider a diagnostic loading trial. What actually changes the outcome? Reproduce provocative compression first, then progressively load the tendon. Isometric can help initially, followed by strengthening and kinetic chain rehabilitation. Recovery takes time, so set realistic expectations so the patient doesn't move from a doctor to doctor. Avoid complete bed rest. Lower capacity prolongs the problem. Stretching is always an issue. Repeated corticosteroid injection as a primary strategy should be avoided. Passive only care with no progressive load component. Early surgical refer before adequate loading trial. So what is a bedside algorithm? Start with load-related history, then palpate the anthesis, reproduce the pain with loading, always perform a neurological examination. Tendinopathy and radiculopathy can coexist, so treat both when clinically appropriate. 6 things to take back. Tendinopathy is primarily a load problem. Rest alone is not the answer. Examine the anthesis and correlate imaging with clinical findings. Examine the tendon before you photograph the spine. Thank you. So now I invite Dr. Haroon for his presentation.
Thank you very much, sir. Thank you for welcoming me to this excellent webinar. My big thanks to Dr. Chair and Dr. Alexander, Dr. Basu, and the whole team. Now, let me share my screen. Sir, can you see my screen?
Yes, Arun, we can see your screen. If you...
Okay. So starting with the...
You have to just, I think, put it in a screen sharing. Oh,
yeah, I'm sharing the screen.
Blow
so
up.
the top, yeah, I think the screen is visible now, isn't it? Yeah.
Yeah, it is visible. Can you put it on a slideshow?
Yeah. So we will start. I think you have covered a lot of important topics here. From the radiological perspective, we will start with the bursitis, and the important bursitis in the area is the trochanteric bursitis, iliopsoas bursitis, and ischiogluteal bursitis. And the trochanteric bursitis is also associated with tendinopathy, as you mentioned, which is more of a degenerate condition rather than inflammatory condition, and same goes for iliopsoas bursitis.
Harun, if you can make the slide into slideshow, we can see a bigger slide, if it is possible.
Let me do
down.
That. Yeah, I think 1 second. So can you see that now?
Yes, yes.
So starting again, we have the bursitis, then we have the bursas, because there are a huge number of bursas in the lateral aspect of the hip. The biggest and the commonest is the trochanteric bursa, which is subgluteus maximus bursa. And this is the one which is most commonly affected by bursitis. The other ones are the subgluteus medius and the subgluteus minimus bursas, which are less affected, but sometimes are also targeted for treatment in terms of when injection is needed or rehab is needed. So just to demonstrate to you the different bursas, so we look at this. This is the gluteus maximus bursa or the subgluteus maximus bursa, trochanteric bursa. This is the subgluteus medius bursa, and this is the subgluteus minimus bursa. So these three are the three important bursas in the lateral aspect of the hip. Now, when we look on the MRI, as you can see here, this is the fluid or the edema, which is deep to the gluteus maximus, and this is bursitis on the MR examination, and this is edema deep to the subgluteus medius musculature, subgluteus bursitis, and this is what it looks like on MR examination. Now, this is another example to show you trochanteric bursitis, where we can compare the trochanteric bursas on two sides, and you can see how there is a lot of white. This is all edema on the right side, which is causing trochanteric bursitis. And this is the ultrasound examination, where typically we don't see much fluid. We only see bursal thickening, and during the ultrasound, we apply point pressure at the greater trochanter over the bursa. And if we see or elicit tenderness, and the finding then correlate with bursitis. In this case, there is small amount of fluid in the bursa. And again, there is thickening of the trochanteric bursa. Ultrasound is very good for doing guided injection. This is the greater trochanter. This is the gluteus medius musculature. This is the iliotibial band. And this is the medial needle, which is sitting deep to the iliotibial band. And this is the plane we inject for trochanteric bursitis. We also see changes commonly in elderly population, middle-aged population, especially women, where there can be tendinopathy. And over time, the tendinopathy can lead to tear. So in this case, we can see fluid and tear in the gluteus medius tendon. This is a patient, middle-aged patient, male patient, unusual sometimes, came with severe acute trochanteric pain, and we could see some calcific change in the gluteus medius tendon. The X-ray examination confirmed that, and then we went ahead with barbotage, putting a needle and trying to aspirate as much as calcium as possible. And you can see this chalky material is there, and this is the saline which has become completely milky in color. The next comes the iliopsoas bursa, which is the largest bursa in the patient, and in 15% patient, it communicates with the hip joint. More commonly involved in osteoarthritis, overuse, and rheumatoid arthritis, and these patients can present with pain in the groin region in L1, L2 distribution. So this is just to show you an example where this is the iliopsoas tendon, and this is the iliopsoas bursa, demonstrating fluid and bursitis. And if required, this is the axial view where this is the iliopsoas tendon. And if required, an injection can be performed into the iliopsoas bursa. Now, coming to the tendinopathies around the hip, we've already looked at gluteus medius tendinopathy, quite common in a large number of patients. The other ones being iliopsoas tendinopathy, adductor tendinopathy, proximal hamstring tendinopathy, involvement of the tensor fascia lata. So let's look at some of the examples. In this case, this is left-sided ischial involvement with left-sided proximal hamstring tendinopathy, where the tendon, which should be black in color, is demonstrating this edema signal change. And this is all the edema around the tendon. And this is tendinopathic change in the proximal hamstrings. And this is the ultrasound examination where we can see all this. This is the normal tendon with fibrillar pattern, whereas this is the affected tendon where the bone has become very irregular and the tendon has become very, very irregular, thickened with these kind of abnormal changes. Another case of proximal hamstring tendinopathy, and if required, an injection can be performed coming from the medial plane towards the lateral plane. We tend often to avoid the lateral to medial because of sciatic nerve in this area. Now, the other thing sometimes we see in practice is, we don't know whether it's a difficult diagnosis, patient coming with sort of symptoms in the L1, L2 distribution and clearly. And, in these cases, we typically what we describe as myalgia paresthetica, seen more in obese and pregnant patients. Ultrasound may or may not be helpful, but more importantly, can help guide injection. So if you look at this video here, for example, in this patient, we can see often we do not see the nerve, but sometimes we can see the nerve more clearly, and the nerve is thickened, which makes the diagnosis more definite. So in this case, this was myalgia paresthetica. So another case where the bone is irregular and the nerve was very much thickened in this area, confirming myalgia paresthetica. So next comes the cases which we will discuss in a moment. Thank you very much. Yeah.
Thank you, Dr. Harun, and we will come to the cases now. Now I request other panelist, Dr. Somajit Basu, to give his perspective on this tendinopathy as a spine surgeon. When as surgeons are tempted to operate on anything, how do we hold back? Sir, you are muted. Dr. Basu, you are muted.
Sorry, I'll just reshare once again. Am I visible and audible now?
Yes, sir. Are you to do the screen share?
Thanks for allowing me to speak on how to avoid unnecessary spine surgery in a patient who has mimickers of the pain in the form of tendinopathies. This is an AI generated picture, as you can see, and all these muscles, very important muscles, are all in one group across the posterior capsule of the hip joint. And you can see that the sciatic nerve comes out to the sciatic notch. And it is a no-brainer to understand that there are a lot of tendons which can compress it, or the tendons may themselves get contracted and give rise to posterior buttock and posterior thigh pain, which is the main reason for which spinal surgeries are done in the lumbar spine. So I would try to restrict myself to lumbar spine surgeries in this 8-minute talk because time limits are there and we cannot cross that. The key topics which I shall be covering upon is persistent pain after spine surgery with a posterior pain or a lateral pain or an anterior pain. Just talk a little bit about hip spine syndrome, which is now extremely well recognized and a proper definition has been added. A case-based learning experience through diagnostic pathways, and finally, an ending slide about surgical decision making. So persistent pain after lumbar spine surgery can be due to a wrong diagnosis, a wrong or possibly an inadequate surgery, and choosing the wrong patient. And the commonest reason for a wrong diagnosis is we are not aware of tendinopathies, which can always be the bugbear of the wrong diagnosis. And as I told you, it might be due to piriformis syndrome for a posterior thigh and buttock pain, or a trochanteric pain generator for a lateral thigh pain, or an anterior hip and thigh pain generators, which I shall come to in the next few slides. As you know, the commonest cause of a prolapsed intervertebral disc, either affecting the L5 or in a forelateral disc, the L4 dermatome, would typically have pain radiating from the back to the gluteal area to the posterior thigh, and usually, if not always, going beyond the knee. In the right side patch, you can see that that is a dermatomal radicular pain, which is virtually diagnostic of a particular lumbar root which is getting involved. And if you have a compressive element in the MRI, you knock out that and your surgery is absolutely bound to give you good results. But a similar sort of situation is a piriformis syndrome, in which the pain usually never goes beyond the knee. And as you can see, the piriformis, if it is tight or if it is compressed, they do compress the sciatic nerve. And however, this pain never gives rise to tingling and numbness in the soles or in the lateral aspect of the foot, but it usually restricts itself to the buttock, and sitting on the chair might give you a lot of pain. There are situations in which the obturator internus and the gemelli muscles are contracted and leading to the posterior trochanteric area becoming extremely inflamed, and this might be a cause of buttock pain. But again, this pain does not go beyond the knee, and this pain will never be of this radicular part. So this radicular pain is virtually diagnostic. If this is followed up with an MRI which shows you a corroborative compression on the L4-5 disc or at the level of the stenosis at L4-5 or a degenerative listhesis, then your surgery is going to succeed. But if it does not show you that, and if the pain hardly goes beyond the knees, beware, it might be piriformis syndrome. Similarly, lateral thigh pain, as has been beautifully shown by Harun, the stir sequence in the coronal cuts can show you that there is a hyperintensity in the area of the trochanter, which might be subgluteus medius or subgluteus maximus area, and that is where the trochanteric bursa is there, and this bursitis can lead to pain in the lateral aspect. Lateral pain mimickers are the L3 nerve root. If you have a L3 nerve root which is getting stenosed at the lateral recess versus if you have this, remember this is the pain generator and not the surgery which you're going to do for an L3 root decompression. Similarly, iliotibial band is something which is hardly ever looked into. Iliotibial band contracture can mimic a lateral thigh pain, and this is extremely important to rule out if you're really not finding out a cause in the MRI and which doesn't correlate with the patient's symptoms. Now, what are the anterior thigh pain mimickers? We know that there are many nerves which come out of the pelvis to the thighs, and out of this, the most important are the lateral femoral cutaneous nerves, which exits the pelvis underneath or through the lateral aspect of the inguinal ligament. Here it is impinged, and that is why the pain is typically a dull numbness and pain in the region of the lateral femoral cutaneous nerve. And this needs to be differentiated from the L2 root pain coming from the spine, or really it might be the femoral and the femoral branch of the genitofemoral nerve, which exists just behind the ascis. That can also be the pain generator. Remember that through the abdominal wall also, the iliohypogastric and the ilioinguinal nerves enter the abdominal wall and travel between the layers of the muscles. And through the inguinal canal, the inguinal nerve and the genital branch of the genitofemoral nerve travel along the inguinal canal, though not to the full extent, but to a certain extent. The differential diagnosis of pain around the hip joint is extremely important. Where hip pain can be either anterior or lateral, but rarely posterior. But the causes might be intra-articular, like labral tears, loose bodies. FAI is extremely important, femoroacetabular impingement. I'll show you a case example also. And there might be a capsular laxity. Whereas the extra-articular important causes would be the piriformis syndrome, the gluteus medius or minimus syndrome, and the iliotibial band contracture. Finally, the hip mimickers can be an athletic pubalgia or sports hernia or an osteitis pubis, which comes down the groin. The hip spine syndrome has been specifically put up into a proper terminology nowadays, and it is a combination of hip and a lumbar spine pain generator. It is typically termed as a combination of OA of the hip and degenerative lumbar stenosis, but there are 4 types, and that is important in clinical practice because a simple primary hip syndrome is one is the cause of pain. For example, an anterior thigh pain can be due to osteoarthritis hip, or it is coming from L2 spinal root impingement, which is known that one is the cause of pain. This is a simple primary hip spine syndrome. Secondary is one has resulted in the other. A hip joint which is osteoarthritic for long, leading to a limp, and that limp produces a partial stress on one side of the lumbar spine, leading to a foraminal stenosis. A complex hip spine syndrome is one in the clinical radiological examination is unable to clearly identify the source of pain. And in these cases, diagnostic root blocks and hip joint injections are used to localize the generator. This is one particular pathology which mimics the other. And finally, it is a misdiagnosed one. That means you undergo treatment for one, and due to poor clinical response, the true source of pain generator is thereafter recognized or unfolds, and that is the misdiagnosed hip spine syndrome. I'll show you one of the few patients which is extremely confusing. For example, in this 40-year-old female who comes with the pain, you can see so this patient says that the pain comes down the anterior part of the thigh, but occasionally goes below the knee also. Why I've put up her hand clinical picture and her knee clinical picture is something which needs to be understood after looking at this MRI. In this MRI, we'll find that there is not much of compression on the left side and lateral recess of the nerve roots of the L2 or L3. However, when we looked at the hip MRI, the reason for the hip joint pain came out to be an osteochondroma, which is causing femoroacetabular impingement. And that's why I had given you the hint by showing that she had multiple osteochondromas in the hand, the Olier's disease, and also in the tibial and the femoral osteochondromas were present. So that was the cause of pain. I sent it across to my hip colleague, and the issue was sorted out. So to end, surgical decision making is extremely important. It's all about avoiding a wrong diagnosis, a wrong or inadequate surgery, and a wrong patient. And as I told you before, wrong diagnosis means that you should be beware of tendinopathies. Wrong or inadequate surgery means you need to have a correct or adequate surgery. And finally, choose a properly motivated patient. That's all I have for today. Thanks.
Thank you, Dr. Basu. And we will start the case presentations now. And I would start it with the one simple case from my side, then start it with Harun. Is my screen visible?
Yes.
So this is a 50-year-old male had a sudden jerk followed by acute pain, and pains aggravated by movement at the hip flexion. Walking with weight bearing became a problem. Turning on the bed on the left side, it was problem because the left side was the pain. Unable to walk free. Pain predominantly mechanical, aggravated by movement. No significant pain at rest. Neurology normal. There was no tenderness as such. Only movement elicited pain, and hip movements were normal, but only pain was there, but you could move the hip. And so this, I would ask my panelists, how would you go about it? But as an orthopedic surgeon and a spine surgeon, we definitely image him first. And so I am putting some MR. So this is the mid-sagittal lumbar spine, and this is the axial sections at L2, 3, 3, 4, 4, 5, 5S1, and these are the hip corners. But the pain was too much, so we requested the radiologist to have a look again because it was not settling and making life hell to change clothes because the leg movement was very, very painful. So every day we used to go and see him. So one of our radiologists caught this. He said, this probably the lateral disc at L2-3, which is irritating the psoas. And so this is the cause of the pain. So we had this short video which causes in the deep fibers of the psoas edema, and with little anti-inflammatory steroids and parthostaching, it settled down. So I looked into literature because never seen psoas irritation producing so much of symptoms, but it did settle down. And Dr. Basu, your comments?
So, Rupinder, this is not very commonly seen, but I did have some patient, one patient about 5 or 6 years back who presented with a similar complaint, and there was a tear in one of the slips. This psoas actually originates from 5 slips, and these slips are they are annular fibers across the discs in the lateral aspect of the bodies of the vertebrae. And if there is a tear in that particular psoas slip, there might be a similar sort of MRI findings. But here it clearly shows that there has been annular tear on the lateral aspect of the L2-3 disc, which is leading to an edema localized of the psoas. So if this settles down well within the next 2 or 3 weeks, then your diagnosis is absolutely foolproof. But if it doesn't settle down, then you will have to get a CRP check to see whether this is a primary or the very initiation of an infective process which is going on.
Okay, thank you. Harun, how would you have treated this patient? Or how would you have confirmed your diagnosis as an interventional radiologist?
See, I think in this case, as you can see, the disc is almost completely lateral, but the diagnosis will be very much relevant because there is edema next to it. When we are doing imaging, if we see presence of edema, along with that, that definitely means that something is going on. In these cases, definitely a CT guided injection can be attempted. Means if there is, as you mentioned, the conservative measures are not working. If the conservative measures of which you already mentioned are not working, then a CT guided, nerve root injection can be considered, which will help obviously, let you know if the pain is improving or not.
Can I ask Harun whether you'd be keen to do a contrast MRI to rule out infection?
Uh, no, Dr. Basu, I think the contrast MR probably in this case will not help much because already there is edema. And because there is already edema, it will not add much to already available information. I think contrast would have helped if there would have been a query like it's a nerve root lesion or it is disc versus something else. But in this case, already there is very unilateral findings. The disc is looking degenerate with kind of fissuring change, and there is edema. So I think that would pretty much point out towards the disc pathology.
I was wanting to initiate, sorry, just one moment.
Yes,
I was wanting to initiate a small discussion on how to understand between inflammation and infection in a SWAS.
So in infection, typically what you would see is that the infection generally does not respect any planes, any boundaries or anything, and is generally more diffuse rather than very, very localized. Whereas in this case, if you see the disc and right next to it is a very localized change. Whereas with infection, you would expect changes at least something in the disc and plate and maybe going much further down. It's more like a diffuse change rather than very localized change.
Absolutely agreed.
Dr. Basu, the inflammatory markers were normal, and if the pain doesn't settle down, how much time would you give for a conservative management, and when would you even think of a surgical intervention, and what would you do in such a case?
I'll wait for 3 weeks and check out with a CRP and CBC to see. It's occasionally difficult to differentiate between inflammation and infection through a CRP alone. But if the patient is not responding to a good non-steroidal anti-inflammatory dosage for at least 10 days, a week to 2 weeks at the most, then I will consider um, uh, other sources of pain. And as Harun pointed out, maybe I'll ask my pain colleague to give an injection to see whether that helps or not. But beyond 3 weeks, I think we should sit up and investigate further.
So this was my MRI, and this happened to me in 2023, and we were traveling to Melbourne for the spine week, and I was in terrible pain, and I then did not take a block, but I did take a heavy dose of oral steroids, but it took a little longer than 3 weeks to settle down. But believe me, the pain and the discomfort were too much, and traveling with that was a issue. Thank you very much, and I'll stop sharing now. We can now ask Harun to.
No, this is the MR you presented, Dr. Chahal, is very interesting. I have been reporting spine. Spine MR is the largest volume of MR we report in our clinical practice as an MSK radiologist. And I haven't come across these kind of, we only very rarely see these kind of MR, but I think your question, how important the diagnosis becomes. And I think because the diagnosis was right, you were
I
able
think there's
to.
only one. I did look into the PubMed literature. There's only another case like this.
Uh, I'll share my screen now. Can you see my screen?
Yes, please.
So let me show you some cases. This is the first case. I don't have a lot about examination, but I'll try and add whatever I can. This is a 34-year-old female with right-sided sacroiliac joint buttock pain and gluteal pain, which was not improving with physiotherapy. And on the MR imaging, we saw that there was severe disc degenerative disease in the lower lumbar spine at L5S1 level. You can see the disc is degenerate. There is end plate irregularity. There are modic edema, degenerative changes. But despite the degenerative changes, I and we could not see any specific neural impingement. So, means obviously there are these degenerative changes, but it was difficult to explain all the right-sided buttock pain, gluteal pain. And thankfully, the pelvis MR was there where we saw that the hamstring tendon was slightly tendinopathic and there was edema around it. So I think that clinched that the main pain generator in this case was the right-sided proximal hamstring tendinopathy with edematous changes, despite having severe disc degenerative disease in the lower lumbar spine, we couldn't, on the imaging, see any clear-cut neural impingement.
Harun, just to put it, and do you then diagnose it with the diagnostic block, or are you then just do a diagnostic and therapeutic both at the same time?
See, depending, we work very closely with spine surgeons. I'll be honest with you, very closely with orthopedic surgeons. And if they feel that this is not the reason, the lumbar spine is not the reason for pain, and they're quite convinced that this is because the problem which I've seen in clinical practice with ischial tendinopathy, symptoms, the patients suffer because they cannot sit properly. And because of the constant gluteal pain, we do get, these patients referred. Previously, we were doing steroid a lot, but now in my practice, I'm doing PRP as well quite a lot, which is more favorable to the tendon. But definitely, we do offer pain, some kind of pain relief in these patients for clinching diagnosis. Secondly, giving them symptomatic relief.
And do you add some local anesthetics to the PRP?
Yeah, we do actually. Yes, definitely. Always we add local anesthetic, and we also ask them to maintain a pain diary to see how the symptoms behaved for the 3 to 4 hours after the injection.
So what is the rehabilitation protocol? How many injection would you give? Because what I see now in here in this is PRP is a routine injections. So
Routine is not needed. No, what I tend in my practice, what we do is if we write in the report that there is no tear in the tendon. So if I see tear, partial tear in the tendon, then I will offer PRP. I will request to the surgeons because there is a partial tear, avoid steroid. If there is no tear, like in this case, but there is a lot of edema, there is definite edema and tendinopathic change with all these findings, then steroid one-off and rehabilitation is good enough.
okay.
If there is a tear, then we suggest that please avoid the steroid and PRP would be more favorable.
And do you refer them to physiotherapy?
Uh, Generally, we work as a team, so yes, they are definitely referred for physiotherapy.
Yeah, thank you.
Dr. Basu, any comments? If you wanted to say anything.
No, I think I would agree that this is a typical hamstring tendinopathy, and the classical thing is that if you have if you examine these patients, if you local tenderness, and the ischial tuberosity is padded up with a lot of fat, so many of these juniors would make the patient prone and try to palpate, which is absolutely wrong. If you have to really palpate the ischial tuberosity, you have to have a knee chest position in which the knees are folded across to the chest on the lateral aspect, and then you can feel the tendon much more, and you have a sharp shot of pain on the ischial tuberosity, which actually clinches the diagnosis.
Yeah, I have a few run-off cases. There's another one. See, in our practice, we are seeing a lot of patients with obviously pain, back pain, and I'm sure you are seeing it. So a lot of time I'm seeing the spinal surgeons are having to refer patients for both low back, for lumbar spine as well as pelvis. And this is one such young patient because these young patients are coming with low backache. And this one had sacroiliac joint region pain and gluteal pain. Now, if you look at the lumbar spine was completely normal. There was nothing in the lumbar spine whatsoever, disc normal, no disc protrusion, nothing to account for pain. The facet joints were fine as well. But when we did the pelvis MR in the same patient, as you can see, this is much more florid, much more severe. The tendon is now even showing small partial tear, which is black change, small. But most of the tendon is very, very severely tendinopathic. And look at the marked edema, which is even entering the ischiofemoral gap, which is sometimes seen in these severe proximal hamstring tendinopathy. So clearly in this patient, there are some symptoms of low backache and other changes, but there is nothing in the lumbar spine to account for it. And the major pain generator in this case we felt was the right-sided proximal hamstring tendon.
Harun, I have a question. Like now in spine, so whenever is a problem in the lumbar spine, and we always now started doing a whole spine screening and probably screening of the SI joints, especially definitely in osteoporotic fractures, infections, or tumors to look for skip lesion. Most of these patients with back pain and all now come with this gluteal pain or mild back pain. Would you then recommend adding a MRI pelvis in such cases?
Uh,
A routine screening?
I think Dr. Chahal, I think the main thing is that it's more like problem solving. You see them in clinic, and I think you're feeling that it is difficult to explain from your examination that everything may be entirely spine. But having said that, I have been spinal surgeons because now they have seen these cases more and more. So I think sometimes they are reluctant not to do other imaging because if they're not 100% convinced, then they definitely add another imaging. The other one which I'm seeing more and more is sacroiliac joint imaging in young patients for ankylosing spondylitis, inflammatory problems. Because every now and then, maybe few months, I see one patient presenting to spinal surgeon and turning out to be ankylosing spondylitis. It is coming from spinal surgeons, not rheumatologists. So I think they are landing up in a lot of surgical practice, these patients. So I think in these,
Another issue is like even if the radiologist were to report such cases of mild tendinitis and all, probably they would not do it. So you have to really sit with them and look through even minor details for them to show you some of the areas. Otherwise, in a normal routine MRI reporting, I don't think they would comment on these things. For them,
yeah.
because I go and tell them this is mild thing, it is normal in most of the scans, especially
So
this
yeah, I think in these problem,
mild trochanteric bursitis, they said it's there in everyone.
yeah. I think in these problem cases, if you're a radiologist, the way you work with them, I think still like little bit mention of your clinical question and your worry does help, and then pinpoint, what the radiologist will then specifically make sure that they try and answer that clinical question.
Yeah, that is where. So we are normally all of us actually go and discuss these cases with them in teaching institutes.
This was an interesting, I'll show you, this is an interesting case. The patient is large body habitus, which is nowadays obesity is rampant. This is 35-year-old female now coming with buttock pain, and the patient is large body habitus, obviously makes examination challenging as well. You can see the amount of adipose layer around it. And the patient has had a pelvis MR and hip MR and no lumbar spine MR done in this patient. Now, there is very minor edema in the trochanteric area, which was very symmetrical to the other side. So, typically in these patients, we don't tend to call it trochanteric bursitis. We often tend to see the L5S1 disc in the pelvis MR, the very lowermost. And then we felt there was something sitting here. And then we looked at the other imaging. So in this case, you can see here, there is a disc sitting at L5S1 level, which is encroaching on the right transiting right S1 nerve root. And the patient has been sent for gluteal pain and only pelvis MRI has been done. And in this pelvis MRI, this is her symptoms being all sorts of gluteal pain, but her actual symptoms are coming from right S1. And there is no lumbar spine MRI done in this patient.
Good case. Very good.
So another one I will show you. This is a patient. She's a 46-year-old female with backache and severe left-sided hip pain. Severe. So she has been sent for lumbar spine MR. If you can see, central canal looks very good. There is only small disc bulge with some small annular fissuring, which is just touching the right-sided S1 nerve root. Now, this cannot really explain her severe left-sided pain symptoms, hip symptoms. So the pelvis MR is also done. And on the pelvis MR, we can see this black colored thing in the trochanteric region. Now, this is low signal on all sequences, seen here also in HCl. This is calcium deposition. This is acute calcific hydroxyapatite deposition, which is a very, very severely painful condition. And in our practice, we often see these land up in A&E department with pain. And I had shown you one case earlier where we were able to do barbotage, but not all case needed. But the patient has lumbar spine MR with right S1 encroachment, but it doesn't explain symptoms. And the symptoms are all coming from acute hydroxyapatite deposition on the left side. And another case which I will show you, this is again, I'm sure you're seeing more and more people being wanting to be fit and gym, going to gym, very fit patient, present with severe low back pain. Patient has been doing intense gym activity. Now, when we look at the musculature, there is edema all around, all edema in the lower musculature, all the edema in this quadratus lumborum musculature, very odd sort of edema. No neural impingement whatsoever, but severe pain. And this is a new condition we are seeing more and more is delayed onset muscle soreness. So these patients, because of their intense muscular activity, these are causing and damaging their muscle, which is leading to this edema and severe pain symptoms. So this is a condition we are seeing sometimes, which we are calling DOMS. So in this case, resting, rehab, I think improved the patient, but no neural impingement whatsoever.
And probably these will definitely go into fibrosis and restriction of
Yes, yeah,
movement,
definitely,
and
yeah.
the cycle will then start. Another thought, Harun, like what they did do in our hospital now is that embolization of tendinopathies, which is a French technique called TAMES or tapes, were a lot of done in our hospital for frozen shoulder, for knee pain, for tennis elbow, arterial embolization of the vessel to that tendon. And your take on that?
I think, sir, I believe in one thing, which is called as friend and family test. So what I will offer to my friends and family, I will offer to my patients. If you ask me, yes, these are treatment which are available, but I find them fairly invasive. And in my practice, I do all sorts of intervention. And I find generally the simpler interventions work good enough as long as you work closely with the rehab team and the physiotherapy team. So these are fairly aggressive, the embolization and all. And the simpler treatment generally can work well.
Yeah.
As I said already, we work very closely with our surgeons and we discuss cases, how to help them time to time. And as far as now, we've never had to refer a patient for vascular embolization. No.
Yeah,
Uh,
even I think this is an aggressive procedure where you take away the pain, the main
yeah,
muscle
no, for even
function
for
of
other
that
things,
patient.
yeah, our nerve injections work well.
So we have a question in the chat box by Dr. Parveen. Sir, how can we differentiate between facet joint pain and tendinopathy? Dr. Basu, sir, and then Harun.
So, a lumbar
Yeah.
facet joint pain would typically be a little bit 40s, 50s, and 60s patient. And they typically have pain due to an impinging osteophyte. And turning in the bed is extremely painful. Extension is painful. If they get down to pick up something from the floor, and while they're getting up, they have an instability, catch a sudden, sharp, severe pain. This pain might go down the buttocks, down to the posterior thighs, but never crosses the knees, and there would be never any tingling numbness associated with it. Usually, they are not associated with walking. There is no neurogenic claudication, but sudden severe episodes of pain on specific postures, extension, turning around in bed. Whereas tendinopathies would be restricted to that particular tendon. Whenever that particular tendon is into place, that means that particular tendon is working because of the contraction of the muscle, then it will be painful and there would always be localized tenderness. Facet joint pain would not have any localized tenderness. Usually, unless there is a fibromyalgia component on it or there is a muscle nodule over it. But tendinopathies will typically have an enthesopathy-like features. That means that the insertion of the tendon into the bone would be painful. Put your thumb across. If you can deeply palpate it, the patient is going to have pain. So these are the differentiating points, I think, between facet joint pain and tendinopathies.
Harun, anything from your side as an interventional radiologist?
Regarding differentiate enthesitis from, is
Yeah,
that
someone refers you to this, and how would you move around and treat him?
see in enthesitis in radiological terms? See, obviously clinical terms are different. In enthesitis, when we say the terminology in radiological terms, we prefer to see edema in the bone. So not only is the tendon affected, the bone gets affected as well. But as Dr. Basu said, it may be subclinical, it may be, sorry, sub-imaging clinical. So you may not see it on the imaging. Point tenderness is important. If we are doing an ultrasound, definitely we put point tenderness directly on the structure. And that is important. See, somebody like trochanteric bursitis, if I am not seeing any tenderness pressing over the gluteal tendon, trochanteric bursal area, very unlikely it is going to be trochanteric bursitis. Whereas on the MR imaging, when we see bone edema and tendon changes, we start thinking more in terms of inflammation rather than mechanical, which may be underlying seronegative spondyloarthropathy, ankylosing spondylitis, especially if the patient is young, less than 45 years of age.
So if you load the tendon, it causes pain. So if you load the joint, it will cause pain. So we have another question. Myofascial pain syndrome versus paraspinal muscle spasm.
Very difficult, because both these entities are very non-specific, very abstract to me. First of all, I have a little bit of a problem in appreciating the word muscle spasm in terms of lumbar spine practice. A muscle spasm is something which in our undergraduate days we were taught, in postgraduate days we were taught that the muscle is standing out. So I believe that the cause is a painful area in the spine. If the spine is painful, it's so tender that if you really deeply palpate it or deeply try to turn around the spinal processes, the patient shrieks out in pain. It's pointless to differentiate between muscle spasm. So something like what Harun showed as DOMS would have diffuse muscle tenderness, and whenever you try to touch it or try to palpate the tenderness, the patients will have a spasm. How do you differentiate that from a localized muscle spasm? Because as you know that these are all multipinate muscles and multiple segments of multiple dermatomal segments and multiple nerve roots will supply these long erector spiny muscles or the longissimus coli. So these patients have very difficult to understand what is exactly point tenderness on a muscle, which our teachers used to teach us as this is localized muscle spasm. You cannot differentiate whether it's underlying bone which is getting problematic, whether it is a fibromyalgic nodule or whether it's muscle spasm proper. Whereas the diffuse dystrophy of the muscle is something which happens. I have very rarely found a way clinically to differentiate between the two, frankly.
And to add, sir, we don't really see anything on imaging in these patients. We don't really see, these we pain physicians, not radiologists. We don't do it, but the pain clinicians sometimes try trigger injections. But these are often the patients where nothing is working and anything is being tried.
And Harun, you will agree with me that the entire spectrum of fibromyalgia, the FMS,
Oh,
the
yeah.
fibromyalgic syndrome, is one of a diagnosis of exclusion. You find nothing on clinical practice, clinical examination. You find a very diffuse history, and then on imaging you find nothing. And then somebody says, "I can find a tight spot. Some rehab guy will come. You need a little bit of stretching to break these nutty corners in the muscle." And so everything is so vague that I would really push it across to my non-surgical pain physician to just make sure that my OPD doesn't get clogged with these patients.
Sir, to put it one, I work closely with pain people as well. He's a good friend of mine. Once he was explaining me because they have a lot of psychologists in their team in pain. within the pain team, and he was once saying that there are hardware issues and software issues. He was saying that hardware issues you can deal with, but you have to be careful if there is software issue. Then it is not, despite you correcting the hardware, the software issue will be persistent, and you doing all the hard work may not bring out the result, which may be liked by the patient.
So there's another question: why incidence of tendinopathy is on the rise? I would answer this. I think it's more of awareness and a better imaging that is we are here at this. And how far are the results of embolization effective? Harun already said he doesn't believe in these newer techniques unless until they are proven, and he is confident of using this on his family and friends. And how does one differentiate a spondylosis pain from myofascial pain and facet pain? We already answered this question in detail, and I want to ask few questions. So this is Rajneesh wants to ask few questions. This is a PRP therapy for greater trochanter tendinopathy. Which type of PRP is prepared? Leukocyte rich PRP or leukocyte poor PRP? And what is the best way to follow up and assess clinical improvement after PRP? Is serial ultrasound required at each follow up? Is clinical assessment usually sufficient? How many injections? And what is the ideal interval? Lot of questions, Arun.
This is, I think,
So,
pasted.
no, definitely. See, I will answer them one by one. So, as I said already, if it is, for tendinopathies, as you had very nicely mentioned, that tendinitis is what most people think it's an inflammatory thing, but tendinopathy is more of a degenerative disease. And with time, as the tendinopathy degeneration, the tendon can develop and often develop partial tears. As the imaging quality is improving, more and more we see concomitant tears in the tendon. When if I see a definite tear in the tendon, I tend to avoid putting steroid in that. In these cases, yes, PRP can be done. I wouldn't worry too much about the PRP, which has been mentioned, leukocyte rich and poor. There are some of them which are claiming that their centrifugation will bring more platelets, so more density of platelets, which is definitely agreed, the concentration of platelets. So those machines, yes. So such machines, what they are claiming is that they will need less course of PRP because the concentration of platelet is very high. But in our practice, generally, I have seen two injections, maximum one or two are fine. The problem we face in NHS is that the PRP is not funded by the government. So the cost is very high. So we try and be, as much, optimal as possible, offer one injection, and we tell them very clearly, please do not expect results before 6 weeks. They if they start thinking it's going to work like magic in 3 4 weeks, it's not going to happen. So I think the best way follow up, yes, there is no need for serial clinical assessment, no need for adding more cost by doing more. Definitely, we do not serially image them again. And as regards your question for serial PRPs, not for tendons, but for joint degeneration problems, we'll end up doing more if required. For mild to moderate knee degeneration, for example, I may offer 2 or 3 steroid injections, but sorry, PRP injections.
Any
So,
role of growth factor concentrate? Just to add this, after this, I'll take up the last question and then we'll end up.
yeah, the growth factor role of not much, no,
Not-
no, no.
And then this is the last question I'm taking. How to manage an acute calcific bursitis of the greater trochanteric region in a 55-year-old diabetic?
I would say initially conservative measures that which you would offer. If that is not working and the calcium looks big, bulky, like I showed in my case, in that case it is very easy to straightforward put a needle and just put some saline and wash it out. So it is outpatient quick procedure. You could put anesthetic as well, so they will get good relief and steroid of course, and yeah.
So thank you very much. I will summarize today's webinar. Not every back pain comes from the spine. Look beyond MRI, find the true pain generators. Tendons can mimic radiculopathy. Clinical examination is key to localization. When it doesn't fit spine, think tendon. And to lastly but not least, new treatments will come, but friends and family test is very, very important if you put it on your patients. Thank you, Dr. Harun. We have pulled you out of your holidays and you come for a national conference. Thank you for donating your valuable time to the webinar. And Dr. Basu is still in scrubs, probably out of surgery or maybe going into another surgery. Thank you, sir, for your valuable time. And thank you, Santoshji. And as such, the man behind this webinar, Dr. Alex, is the dedication and devotion to teaching and promoting healthcare and healthcare industry in the associations. We interact with them for everything. Thank you, sir, for such a lovely.
My pleasure. And thank you, Rupinder. Fantastic job. Very interesting. And you kept so much to time. I think there's been a huge participation. Yeah, Rupinder, we'll request you to close.
So, as I
We
already
can
said,
just talk a little bit about Anbai also. No, I think all our colleagues may not be aware of it.
yes. So ANBI is an association of national board accredited institutes in the country and is founded by Dr. Alex, Dr. Rajshekharan and Dr. Devi Chetty. So it is actually a link between the DNB, FNB institutes in the country and the national board. So we then do a teaching and training program for faculty development, and we have regular webinars. We had one on medical legal back pain, and we are having one on 11th of this on finance management for young doctors, because now young doctors feel that they do not earn much. So I tell them you can earn much. How to save that, we'll teach you. So this is going on. And we have our national conclave in Bangalore on 29th and 30th of this August. And we are very happy that our senior colleague, Dr. H.S. Chabra, is the current president of ANBI, and he's a world-renowned spine surgeon. And so ANBI, we will definitely utilize all of your talent in ANBI to bring in more such webinars. And thank you for today. Thank you, everyone.
Thank you and good night.
Thank you, sir. Thank you. Thank you. Good night, sir.
Thank you.